So this case, very interesting, and that is what a lot of discussion happened with Kendra and Vinny, and we are going to talk about this patient. Let me just go back. Okay, this patient, which exactly is the, I would say, the trouble. Trouble is like DES coming back. So we thought the DES has cured everything, but no. DES restenosis, same thing. We thought TAVR is the final answer when we are doing it. Patient probably won't live more than 10 years. And now we actually have seeing some failure even before. And of course, those who outlive the valve, TAVR valve life. Now, this patient is an 82-year-old, has symptoms of heart failure and heart block, and has a transfemoral TAVR using 23 millimeter S3 -1 in March of 2019. So about like the 40 months ago, 3.5 years. Coronaries are okay and start having more shortness of breath and had a echo done, which showed severe prosthetic stenosis with the mean gradient of 36 and valve area of 0.67 and velocity of about 4 with minimal PVL. Clearly a degeneration of the valve with a good ejection fraction. And this is the echo, which have been recorded, but now we'll go to the live echo with the stem laracus on that side.
Yes, good morning again. So this is the mid-esophageal views showing the LV function and appears normal LV function, actually 3D, ejection fraction 68%. Since you have the 3D, this is the mitral valve 3D, surgeon's view, minimal mitral regurgitation.
Yeah.
This is the 3D of tricuspid, minimal tricuspid regurgitation, and moving to the aortic valve. As you can appreciate, the leaflets are very thickened, calcified with decreased excretion, and also there is mild to moderate aortic regurgitation. The short axis view, again, there's almost fusion of the right and left cusps of the prosthesis with a mild to moderate AI. And as you can see, the peak velocity we got here is 3.26, as you say, that after the procedure, the next day, the velocity was 1.2, maximum gradient 42, mean gradient 21, valve area of 0.7, 0.8, and the index 0.5 with stroke volume index of 37 ml. Pressure half time of the AI 446, so mild to moderate. And we did a 3D measurement of the stent of the prosthesis at LVOT, which comes about the same as the CT, 3.6 centimeter square area, 6.7 perimeter, and also we measured the height of the left main we got 1.3 centimeters. And also, I know it's important for the left main in this case. Also today we can do flow, and this is the flow of the left main by echo. Thank you very much.
Great, and we'll get some opinion from the experts on the panel, and because this is a little unusual case for us also, and patient does not have renal failure, creatinine is good, and we know that it's not a halt. Clearly, it's a degeneration of the leaflet. Well, we'll ask the opinion, but let me just go through quickly. Echo has been done, and this is what the tie we wanted to show you, and then we'll come back and ask the question. This is the case back in March of 2019. As you can see here, height of the left, the right, because of the just 10, we did a protection with a coronary wire at that time, and these are the valve, and this is where we had it. Clearly, the top of the S3 frame is against the top of the left main, just at that level. And the patient did very well. It looks quite good. We didn't feel, echo-wise was good also. We didn't feel that there is under expanded valve, although it was 23 minus 1 cc at that time. And just in 3.5 years, which is unusual for this type of patient, which does not have any renal failure, has come back. So now, of course, Gilbert has reviewed this case very in intricate detail. Maybe we can ask the faculty to give the opinion, the Vinny, Kendra, and others, that what do you think went wrong when we deployed this patient, this valve 3.5 years ago?
Yeah, perhaps show us back the aortogram while the panel is talking,
okay.
So that they can refer to it. Yeah, go ahead, Vinny and Alex.
Question, George, regarding the mechanism of failure. Because is echo enough to understand? Because generally, less than 4 years, we think about heart and leaflet thrombosis. And according to Dr. Sharma, this was really the mechanism is different. So we generally ask these patients to undergo CT scan to make sure that you understand what is going on. Is echo enough, Stan? Are you comfortable and
Yes.
you are sure?
Yes, Alex. Good to see you this morning. Yes, there is no heart. Heart looks very different. This is, as you can see, calcified leaflets with a commissural fusion of the left and the right cusp. So, I mean, heart looks completely different. And I know the gold standard is CT, but
No, but we did the CT. No, just to say that yes, we did the CT on this patient, thinking that may be causing this gradient, and CT was clearly, was not no halt. So
No, we review-
Stem just said on the echo was nothing in terms of the halt and not the CT.
Clearly premature.
no
Clearly,
CT, no heart.
clearly premature degeneration. We're gonna come to the halt when you show us a CT. But let Dr. Bapat comment.
Yeah.
He wanted regarding this aortogram of the first case. Just the final result of 2019. Might be any clue now in retrospect, or maybe not.
So I think, again, this highlights a point I made, Dr. Sharma, just in the talk, that in such situations where coronaries are at risk, it's a smaller valve. We know that patient may need, a redo procedure. Should we start thinking of implanting it slightly lower? And we do that in our center now for patients, especially on dialysis, where we know they're going to come back sooner. So we have started identifying patients where we have proactively started implanting in lower, so as to keep that window of second TAV-in-TAV open. But otherwise, I think beautiful result. I think the valves expanded nearly fully, but the CT dimensions will educate us a bit more.
Yeah, Dr. Grubb?
Okay.
Not to criticize the organizers of the conference. There are a couple of things that I worry about in this particular case, and the point of my presentation was make the first valve the right choice and then implant it perfectly. And here I understand why you landed deep to preserve access to the left main, but then selecting a 23 millimeter and leaving a CC out, I question a few things. One, do you have an underexpanded valve that has some pinwheeling of the leaflets from the time you started, so that the valve is not functioning well immediately? Next, is there some patient prosthesis mismatch? Was this too small a valve for the patient, and could we have done better with a different valve? So ultimately now we have 3 commercially available valves for these older patients, and would it be a better first choice to either use a supraannular self-expanding valve or a self-expanding intraannular valve? Would you have gotten a different result? And I would suggest that those things could now be explored. And there's even new technology doing AI simulation that could help us answer those questions. I mean, I think at the time, 2019, we were doing the same thing.
Right. Well,
And just to update on that, this is an unusual case. I mean, we have seen some cases of degeneration, and I'll ask Anu to comment on that. Particularly, those were the cases which, I'm not talking about halt. Halt has been ruled out, but valve degeneration, the renal failure patient. But this was really, very unusual case, and based on the data that whether with the small annuli, this will fill into that small annuli or a smart trial type of case, and with a Swiss registry, hemodynamics a little better, but long-term reintervention was equal in both self-expanding and balloon expandable group. Anu,
Yeah.
have you seen?
Can I-
Dr. Kapadia has a comment. Go ahead.
Renal failure patient.
Yeah, I have one comment, Dr. Sharma. Samir, so one thing we have seen is that when the sinuses are small, so see this patient
Yeah.
has a very small sinus. And this kind of patients, so we are ready to write our paper too of saying that what is the sinus washout time. These patients, I like to give them anticoagulation after the TAVR, because I think your valve implantation is perfect, and I think 23 minus 1 this is what I would have done. But I think that this kind of valve anatomy, if you see, because the pannus grows from the sinuses also. So you many times, I don't know what you found on the CT scan, but many times the growth is from the commissures of the valve growing inside. And this is because it's touching the walls of the
Sinuses.
aorta.
Yeah, let's look at the city though. If you have any further discussion, please advance
All right.
towards the
Let's
city.
keep going. Yeah, sorry. This is the tower app. So index tau and measurement, we have already shown it, right? This is the index time, correct?
Yeah, so you can see here that the valve is underexpanded, right? So you can see the mean diameter on the outflow and inflow is around 350. But the waist, here you can see that this is a work courtesy of Miho and Minneapolis Heart with Vinny. That is just 20. So it is underexpanded despite 23 minus 1. Next slide.
My question is, anyone want to comment? Are you doing two inflations? Like in the coronary, we do a stent, very commonly two inflation. Are you routinely doing two inflations in these cases? When using a small valve particularly?
Hassan.
The risk of annular damage is pretty high, so unless it's really underexpanded, we don't.
We do sometimes do a two-tap approach, especially if we have concern on root injury. So sometimes we underfill by 1 cc or 2 cc as you did in this case, and then sometimes do a post-dilatation if on TE it looks good. But I appreciate very much Kendra's comment on simulation, and in line with what Samir said, we're working with DASI simulation to try and predict these early degeneration.
Yeah.
And the small sinuses significantly affect a parameter called the normalized circulation. So this is one of the important factors, as well as having a waist. So it is very multifactorial. It's very hard to understand. I'm interested whether also the commissures were aligned in this case, because that is also a factor.
All good points.
Even for the balloon expandable, yeah, that is correct. So this is now redo tower app. Now identify coronary risk plane, so which is
so you can see that here, actually we got the, and Vinny worked up this case with us, and you can see that the left coronary, and you can see that on fluoro later on, just sits right at what we call the risk plane. So pretty much the top. So that makes it potentially more favorable, and next slide. You can see that here, just to educate the audience. Remember, the top of the frame is not where the leaflets are. Actually, it's where the commissure taps are. And you can see the blue line being the neoskirt plane where it will become a tube graft versus the coronary at the bottom of the left main is pretty close. It's pretty much level. So this does give us a little bit more comfort, but obviously this is not the same as coronary access. Next slide. So you can see that this is our own analysis, pretty consistent. Next slide. And then the app then tells you basically what is a second valve. So here's the big question, right? You can see the valve is already underexpanded. So next slide. And so we looked at the potential number one in implant position, as Vinny has outlined in his talk. And then the next, if you move forward, you can see that here, because we're essentially the same. Next slide. And then so you have low risk acute coronary obstruction. Next slide. And then so what you're looking at then is how do you size the second valve? So this is where intuitive does. You basically average the three measurements that we did, and you can see it's around the range of a 20 SAPIEN actually now. Of course, you want to look at the BSA as well to look at ppm, and we calculate that for this patient. And you can see if you put a 23 in there, assuming it expands fully, which probably won't be the case, will not have ppm. But even with a 20 S3, you only have moderate ppm here. So the discussion question with us was that should we do 20 plus 1? Or 23 minus 1. And the consensus, at least when we discuss based on the sizing, is to go 20 plus 1. What do you guys think on the panel? The EVOLUT is another interesting choice, but you can see the root is rather small. So we were concerned about this patient is only 82. It's not 92 in terms of coronary access afterwards would be challenging with that such a small room in terms of STJ to the top of the S3 frame.
So let's take the vote.
Yes.
People will say 20 plus 1 or 23 minus 1. Knowing 23 minus 1 was done.
Dr. Herman has a quick comment. Dr. Herman?
So there's no data, obviously, to answer this question, but I do think if you put another 23 in this small valve, it'll be even more deformed. And although maybe you'll get a slightly bigger valve area, at least predicted-wise, it's going to be deformed, and probably in this patient there must be patient factors that led to the early structural valve deterioration, and they might be even worsened the second time. So I'd probably go with a 20. Moderate ppm in most studies has not been shown to be a predictor of bad outcome, and particularly in an 85-year-old. So I'd probably go with a 20. My only other comment is the The left coronary is predicted to be safe here, but it still looks very, very close. And I would have a very low threshold for coronary protection at the very least here.
Yeah. Beautiful. Good. So both we are kind of, you didn't say it, but we heard it because both your opinions all have been done. We clearly coronary risk assessment, which we had done. We, the wiring at least, not necessarily the stent, we thought. So this is where we are now. Alignment here, the alignment of the...
Yeah, so, as you know, balloon expandable valve, at least in current generation, can't be aligned with the SAPIEN 3 and even ultra resilient platform. So you can see there's been moderate commissure misalignment. You can see where the commissures are. But thankfully, this case, and you see it on fluoral, the trough of the outflow sits actually at the left main. So you see that we're able to pass the guide through from the top versus through the frame, because that's really the big question here, right? How would you protect?
We showed both.
Right, exactly. And Sahil and Dr. Kinney will show you what the visualization of both. Okay. Maybe we just fast forward.
And the iliac is good, so the rest is all. Let me just complete and go through it.
Yeah.
So this was the redo positioning, left with the left main protection. That's our plan. And we changed the approach, as you said, 20 millimeter plus 1 cc with the wire protection. So tell us now, both of you, where we are. Go to the fluoro, please. Yeah. Okay. Each of sentinel has been done. Yeah.
Yeah, that's take a picture with a guide. Yeah, show us this picture with a guide. Yeah, very easy access. Yeah, very easy.
Safe looking, to me, I think the left main will be fine. And again, the decision between 20 and 23 is a tough one, because I don't know that what I would do personally. I like the idea of 23, but I know that everybody feels that 20 is a better idea.
I didn't hear any comment regarding EVOLUT here. Anyone might use EVOLUT? Dr. Grube?
That is an option, but I think it is...
Dr. Grube, not too enthusiastic about EVOLUT either. Okay, we move on for this case.
Okay,
yeah.
Good.
Okay.
Good.
Go back.
Yeah.
The question now, protection-wise, are we going to leave the guide above or through the cell? I think you should leave it above.
Above.
Not through the cell.
Yeah. Okay.
So we're ready.
Good. We're ready?
Yeah.
We cross the valve. We can show that. I think we just used our usual technique to cross. Earlier also you did.
What was the gradient when you crossed?
We can we show
the hemodynamics on one side
by the side?
It's about same 35 that we got other way.
Yeah.
And now this is in the anesthesia situation, so probably 10. I always say give the 10 for that.
Maybe you could also discuss what your coronary protection technique
Yeah,
is. Do you leave a guide in? Do you put a wire down? Do you put a stent?
The wire and guide floating above. That's why they decided.
Yeah.
So the concern with
So
that is-
usually, like last time also, we felt that the guide catheter and use the guide catheter as to inject the aorta, for your injection. So you don't need to put an extra pigtail. Use that, taking it out, and leave the wire. So we last time also we just did the wire protection. We knew about, but we did not do the stent. So many cases we will do, and one of the case which will be shown later today, we had to protect both of them. And after the deployment of the valve, we did a double RCA left main chimney stent. But this case, that time we thought the wire, and Sahil was very confident, probably, took the edge. I mentioned that opinions of our faculty there the same way, that just the wire protection will be good enough. And that is what we are there now.
Now, have we discussed if we have to pre-dilate this previous?
So let's ask the panel. So because the valve is underexpanded, we feel that we should pre-dilate this just to make it easier for the second valve to cross. I know some people don't do that or not in favor of it, at least in my personal humble opinion, that we feel that it gives a little better landing zone. Obviously, we'll wire the left main afterwards. This is just to optimize what I call, because we've seen that in Jannar has done some work on it, that you cannot really post dilate and expand the frame afterwards, with two frames in place.
Okay, 180.
Base 180.
It would be interesting to inject contrast when you inflate the balloon to see what happens with the coronaries.
Well, there is a waste clearly. Yeah.
Okay, stop it.
And
What size balloon was this?
20 size balloon, I assume.
This is 21 true. 21 true.
Off. Yeah, see now actually, you know that little dumbbell type of waist last time? The question was, and that's what I asked the question earlier, should we have done the second inflation back then without taking the -1 cc out, and maybe that waist would have disappeared and the healing of the valve would have been a little different and not reached in 3.5 years.
No, that's a very good point, Dr. Sharma. I mean, we would now actually intentionally undersize and optimize the frame expansion of some of these valves, right?
Yeah.
In borderline anatomy, obviously, for concern of rupture, and we published papers showing that there was no gradient difference even when we but you get the pro CT, they're more normally expanded.
So this is a very good sign. You see the catheter just went through the STJ into the coronary. So
We'll say that, please. Yep.
So what is the role of just balloon? This is the question.
Yeah.
So like, why don't we stop?
I mean, yeah.
It's a pretty
Don't,
calcified.
yes.
If
No,
it
but
is-
I
I
would
don't know
say
how
that,
calcified,
Samir,
that's
if
why.
it was only under expansion, then yes, which we have done few cases. But since there is a clear-cut valve degeneration both on the CT as well as on echo, that's why we thought we put a valve in.
So we actually showed a case on that with an EVOLUT that was degenerate. We were worried about coronary obstruction, right coronary.
Yeah.
We actually did a live case and we ballooned it before, actually 6 months ago as a palliation.
Yeah.
Patient Jehovah's Witness, inoperable. And then but he felt better, but then 3 months later, the gradient came back and we have no choice but to actually put a second valve in.
Let me a new.
In that case, we relate to one of the valve meeting, Hyderabad valve last year, because balloon alone didn't work.
Give me wet.
Dr. Sharma, the other important thing
Yeah.
is the slight difference is here if the guide goes easily, we just put the wire. But if there is difficulty in placing the guide, we also
sutured
put the
already.
stent. Because it's extremely hard to pass the stent later.
Yeah, absolutely. No, fully. There was, if any question was that we'll have a trouble, we were actually prepared. So actually, when I sent, initially we were thinking that we put a preempt stent. But then by looking at it in multiple views, and today when they did the picture, we clearly, everybody reviewed it, and it felt that there's no need to put a stent. I think the wire alone will be okay.
Yeah, indeed, the way the previous angiogram, etc., looked, there was more concern for a left main proximity than it actually is in reality. So that was a favorable revision of the plan and simplification after the original angio before. And someone, obviously, just for the audience purposes, someone is actively pulling the guide or holding the guide so it doesn't dive even more in during the advancement of the valve, because one catheter can push the other a little bit.
So is this a 20 or 23? What did you choose in the end? 20?
This is 20 plus 1.
20 plus 1.
Plural.
Yes.
We'll see.
So artificial 21. Man-made, although it's not actually 21, it will be 20.8.
Artificial, yeah.
Another issue you have to worry about with a 20 is that it is a shorter frame. So you have to worry about leaflet overhang, and you're positioning a little more carefully than with another 23 and 23.
So I think
this
we are
will be
good?
okay
Yeah?
because it's going to fully
address
foreshorten
that
from both
question,
ends.
Ho, is you do outflow to outflow here, then you will be fine. In fact, you can go down up to Kamisha tab, and then you can align it there. So this will
everybody,
work quite well.
We don't need to inject.
Low.
how do you like the current position where they are?
Okay, good.
Not more.
How
Okay,
are
180.
Let's test. Let's test.
everybody sort of likes it here?
No.
Everybody likes it here. I'll make sure the guide is quite out of the left main.
Okay, good.
Okay, off.
So as you see that we always test before we inflate,
Okay, ready?
just to know that where things will be.
Long pacing run.
We are ready now.
180.
Very slow.
Going up.
Very slow.
Yeah. Kind of went up a little bit, but let's see.
No,
It's okay. Don't worry. Don't worry.
Very good.
Okay, I'm
Excellent.
full.
Exactly.
8.5.
To 1,000.
Yeah. Yeah, very nicely. It's very low blood pressure during the pacing. That
Let's pause for
hopefully
pause.
goes for a very good result.
Let's take a picture first.
Yeah.
Let's take a coordinate picture, please.
Yeah.
Okay, so hemodynamically good, ECG is all right.
No, PE up, please.
Tee up, please. Tee up.
Yeah.
They're taking a left main flow picture also from TE.
Yeah, now you can do it. Now put the TV.
Well, should we post-dilate now? There's I mean, just post-dilate.
Yeah, go back.
All
So
right.
again, this is our Mount Sinai technique that we like to pre-impose to optimize the second valve frame expansion as well. So
Particularly when one of the big mechanisms was the little waste of the in the middle. Yeah, let's go.
Okay. I want to check something.
So Vinny looks pretty good there, huh?
Looks
From
very good.
placement standpoint.
The initial impression, everyone here, is very positive. Very perfect implant height-wise, and let's see how the post-deal. You're going to plan to do a post-deal with 23 true. Is that your idea?
no, we'll use the same one.
Same one.
And do you want to add one more CC inside, or that's okay?
It's fine. We can add
Why
one.
don't you add one more CC? So now again, man-made.
Man-made 21.
T is okay?
Yeah.
21.5.
The left main.
So I think the question I would
The level of
ask
the left main
Dr.
is
Sharma is
I'm sorry, what?
Do you want to add one more or you're okay?
if you are adding one
at the level of the
cc,
left main.
We can change, look at the flow. We can look at another flow afterwards.
No, I'm not saying to do anything, going higher up.
Give one CC.
So Gilbert, why don't we use the 21 true balloon instead? Because it usually gives better expansion. So instead of using 1 cc extra in
What's
the
the guy?
top-line balloon.
Yeah, that Dr. Bapat brings out the true balloon possibility for a more optimization.
Me little flex.
I am advanced.
Okay.
I guess
So
another
one
time.
thing is you center the wire when you cross, right? Because otherwise you get stuck in the outer curve. That's a trick that we've seen as well with TAV-in-TAV, that you rub against the metal frame. So
Now, where is the force of the balloon? The maximum force, the middle of the balloon, needs to be exactly where the least
180.
expanded area is.
Hopeful. Now will be like 21.5 millimeter. We have added 2 CCs now.
Yeah.
Okay, good.
Good.
8.5.
yeah, you see it. It actually.
And went to 8.5 atmosphere. Get a picture ready.
Off.
Yeah.
Unflexed.
Yes, I did.
Okay, we'll do some hemos, okay? Keep a pigtail, please.
Right.
Sahil, I'm walking it up, okay?
Get me a picture.
Okay, go ahead, Stan. You got wire?
Hold on, let me do a coronary picture.
Once I can take this one up, corner picture, so that we take that thing out. Good.
Even better now.
So far good. Okay.
Corner picture even better. Excellent.
Yeah.
Can you put some color, please?
Okay, we are doing a pigtail now.
Oh.
Take it out, please. Take it out, please. Take the color off. All right.
And actually looking quite good. So we're probably a 1 millimeter below the top frame is slightly, maybe just a 1 or 2 millimeter below.
Put some color there.
Definitely not above.
Yeah.
That's the key.
But it's interesting that a 20 inside 23, when we fully expanded here, is actually the same height.
Yeah.
You see that here, right? Inside.
Because it doesn't have
It doesn't,
anything
yeah,
outside.
exactly. It doesn't expand more. So this is something important for the implanters to know, that it might not be actually shorter than actually the first valve. You can see that this does not fluoroscopically look shorter at all. In fact, it's the same. And we'll do a post CT on this patient afterwards as well. So,
It suggests that.
Stan, how does it look?
Yes, looks great. Looks great. Can you put
Fully
the
dilated.
Show the echo.
lights, please?
Yeah. Wow.
Short axis, also you can see good flow in the left main by coronary flow by echo. Can you take that, Prof? Yeah. Okay, take that, long axis. Long axis.
Yeah, it's a Resilia. It's 120 Resilia.
Great opening. Let's put some color.
The other thing you know, I don't know if you noticed, actually, the valve tend to ride up a little bit as well when the inflation.
Then go to stomach.
So it's important for the first operator to control the position at the end. It's a slow inflation that you saw there. Because otherwise the valve may end up riding a little bit higher than you want.
Good.
Beautiful hemodynamics.
That's good. Yeah.
Can we share the hemodynamics, please?
It's good. Perfect.
No PVL.
Yeah.
You have
Show the hemodynamics, guys. Normal, no gradient.
Yeah, that's great there.
Absolutely no gradient. And if it looks good, we are ready for the second case.
Yeah, that's the measure.
Yeah.
So that's Stan, can you do a
Very
great
good.
influence as well on the PE?
Here, you see, stick this.
Did we? Yeah.
We're going.
The second measure.
Will you give anticoagulation to this patient?
Anticoagulation decision for this patient is probably pending, but will be closely considered.
I think we should give it, you know.
So no, yeah, well, the only problem is, that she had 3 falls and she had 1 intracranial hemorrhage about 9 months ago.
All problems here, all problems in one case. All problems in one case. So valve-wise would be a benefit. Patient-wise, I don't know about that. So we'll rethink about it.
This is a patient where you will do a follow-up CT at 1 month, because this is very important.
Yeah, very good, very good. Definitely CTA at 1 month in this complex repeat valve cases is quite well taken recommendation. Yeah, definitely.